Today we are going to talk about feline panleukopenia in cats. Feline panleukopenia is basically the cat version of a severe parvoviral enteritis, and it is one of the big do-not-miss diseases in young, unvaccinated cats. It is caused by feline panleukopenia virus, a very tough, non-enveloped parvovirus that spreads through feces, vomit, secretions, contaminated cages, shoes, hands, bowls, and bedding. The scary part is that this virus can survive in the environment for a long time, so isolation and proper disinfection are just as important as treating the cat. Pathophysiology-wise, the virus attacks rapidly dividing cells, especially the intestinal crypts, bone marrow, and lymphoid tissue. That is why these cats get vomiting, diarrhea or sometimes no diarrhea at all, severe dehydration, fever, abdominal pain, and a dangerously low white blood cell count. In very young kittens or kittens infected before birth, it can damage the cerebellum and cause lifelong tremors, incoordination, and cerebellar hypoplasia. On blood work, the big red flag is panleukopenia, meaning a severe drop in white blood cells. A normal cat white blood cell count is often roughly 5,500 to 19,500 cells per microliter. But with panleukopenia, the white blood cell count may drop below 4,000, below 2,000, or in severe cases even down near 50 to a few hundred cells per microliter. The low white count is usually from neutropenia and lymphopenia, so you may see neutrophils below about 2,500 per microliter and lymphocytes below about 1,500 per microliter. Thrombocytopenia and mild anemia can also occur. Diagnosis is usually based on history, clinical signs, a CBC showing leukopenia or neutropenia, and a fecal parvo antigen test. A negative test does not fully rule it out because shedding can be intermittent, so PCR may be needed when suspicion is still high. Also, modified live vaccination can sometimes cause a positive fecal antigen or PCR result for several weeks, so vaccine history matters. Treatment is aggressive supportive care. These cats often need hospitalization, isolation, for crystalloids with potassium correction, dextrose if hypoglycemic, antiemetics like meropetant at 1 mg per kg/4 or sub-Q every 24 hours, and sometimes ondansetron for severe nausea. Because the gut barrier breaks down and bacteria can translocate, broad-spectrum injectable antibiotics are commonly used, such as ampicillin sulbactam around 10 to 20 mg per kg/4 every 6 to 8 hours, depending on the patient and clinician. Early enteral nutrition, warming, glucose monitoring, and good nursing care can be the difference between life and death. Prevention is vaccination. Kittens generally start the FVRCP series at about 6 weeks. Repeat every 3 to 4 weeks until 16 to 20 weeks. Then booster later and continue on an appropriate adult schedule. So the big takeaway is, isolate fast, test early, treat supportively, protect the gut and bone marrow patient, and vaccinate before this virus ever gets a chance.